is not only important for the examination, there is so much of the morbidity and mortality involved with the fractured neck of the femur, and it can happen in all the age groups, and the difference in the treatment options are the contrast. So let us start the topic fractured neck of the femur, and we will start with a MCQ. Which of the following injuries is anticipated to have a 20% chance of mortality and 50% chance of loss of independence at 1 year follow-up when sustained by an 85-year-old female? Is it intra-articular distal humeral fracture, distal radial fracture, femoral neck fracture, trimalleolar fracture dislocation of the ankle, or is it periprosthetic distal femoral fractures? So all of you know it because I am taking this class on the fractured neck of the femur. Definitely the answer is femoral neck fracture. See the another one. A 65-year-old patient is diagnosed as having a fractured neck of the femur grade 4. His medical history is significant for hypertension, type 2 diabetes, and dialysis-dependent chronic renal failure. Based on these risk factors, what is the most likely post-operative mortality at 2 years follow-up after surgery? So he has been gone for the good medical management, good surgical intervention, and still there is a mortality. And how much is the mortality percentage? 13%, 25%, 45%, 60%, or 100%? We'll try to find the answer somewhere during the course of our talk. So let us understand simple things on this one. It can happen in both the young and old. Of course, the young people, it can happen in two ways. One is the high velocity injury, definitely, but it can happen with the unaccustomed strenuous activity or changes in the activity, as happens with the runners or endurance athletes. Elderly individuals, they are mostly with the osteoporosed bones, and it can happen in those population. So as far as the etiology is concerned, we have seen the stress fracture that is important for the training individuals, that is to be seen. This is called as a stress fracture. Other factors can be low bone density, can be abnormal bony composition, dietary deficiency, biomechanical abnormalities, and menstrual irregularities in females. And over and above, the predisposing factors could be osteopenia, poor physical conditioning, systemic medical conditions. All these actually demineralize the bone along with the temporary inactivity. Let us examine each time we are given a case of the femoral neck fractures, we have to answer it. The women have the highest incidence of this stress fracture in the femoral neck. And why so? The reason is simple. It is partly due to the mechanical differences and anatomical variations between men and women. The differences in women include various stride lengths, the number of strides per distance. They have the wider pelvis, and because of the wider pelvis, there is a coxa-vara deformity already there, where the shearing force is more on the neck, and there is a genu valgum and the knee. So all these factors contribute towards more number of fractures. Also, the women have 25% less muscle mass per body weight than men. And there is, in old age, lack of protective estrogen, which leads to decrease in bone mass. Now, whatever we are saying, the epidemiological studies say 5 to 10% of all stress fractures are from the femoral neck. But remember, the total number in the USA that has been estimated, it is 250,000 population, they are having this problem at a given time in a year. And it is expected that this will double in 2050. So aging population is slowly increasing. And remember the race, it is highest among white women, then white men, then black women and black men. The femoral head articulates with the sternum that we know. And the femoral neck connects the head to the shaft, and it connects in the region of the lesser and greater pointers. The synovial membrane incorporates the entire femoral head, but it incorporates only the partial of the neck, and that difference must be remembered. Anteriorly, it covers the whole of the neck, but posteriorly, it covers only the proximal half of the neck. And also remember, the shape and size of the femoral neck can vary very widely. Let us understand the blood supply and its importance is there. We will discuss it in far more details. The blood supply of the femoral head usually comes mainly from the three sources. One is the medial femoral circumflex artery, the lateral femoral circumflex artery, and the obturator artery. The largest contribution of the femoral head usually comes from the medial femoral circumflex artery. And the medial femoral circumflex artery, it supplies the blood through the lateral epiphyseal artery complex. And these arteries courses along the posterior superior aspect of the femoral neck towards the head, whereas the lateral femoral circumflex artery supplies the majority of the infero-anterior femoral head. Infero-anterior femoral head, remember, they are not taking part in the weight bearing. So there are certain rings formed for the anastomosed arteries. One is the extracapsular arterial ring, which forms at the base of the trochanter. The second is the ascending cervical branches of the arterial ring, and that forms at the base of the neck or at the base of the, that usually forms at the base of the head. And the third one is arteries of ligamentum teres. So extracapsular ring, you can see this extracapsular ring, which is forming at the base of the neck. And remember, this medial circumflex femoral arteries, they are supplying the head through the ascending cervical branches, which is coursing through the synovium. This is the lateral femoral circumflex artery, and it supplies the infero-anterior part of the head, which is not taking part in the weight bearing. This is the second part, and the third one is coming from the ligamentum teres. Now we are concerned with why is there disruption of the blood supply of head if there is a fracture in the neck of the femur. The femoral neck fractures, usually when there is a fracture of the bone, it invariably disrupts the blood vessels going through the endosteum. So endosteal blood supply to the femoral head is severed or disrupted. If the fracture is widely displaced, they will tear the synovium, and thereby any blood vessel which is going through the synovium will be ruptured. And due to hematoma formation, the pressure within the capsule is increased, and thereby ascending arteries are compressed. This situation is called tamponade. Displaced fractures tear the ascending cervical branches that stem off the arterial ring supplied by the circumflex arteries. So these are the reasons you must remember. So there are classifications which comes into play. There are three main classifications that we talk about. One is the Garden classification, which is most commonly used and most commonly asked to the students in the examination. Another is the Anatomical classification, and third, the Powell's one. Garden talks about the fracture which is complete or it is incomplete. They talk about if it is complete, is it displaced partially or fully. Whereas Anatomical classification talks about the location of the fracture anatomically, and they will tell you about the blood supply which is disrupted and how much it is disrupted to the head. And the Powell's talks about the angle of the fracture line, whether the shearing force is more or shearing force is turned into a compressive force. That is the difference between the three. So since 1961, Garden classification is still being followed, and it is grade 1 is incomplete fracture. Or even if it's complete, but if it is impacted, usually impacted in the valgus position, still it is called grade 1. Grade 2 is a complete fracture, but there is no displacement. Grade 3 is again complete fracture with partial displacement, whereas grade 4 is complete fracture with complete displacement. This sometimes it is very difficult to ascertain difference between 1 and 2 and 3 and 4. And so there is another way of understanding the garden is to classify according to displaced or undisplaced fractures. That is good enough. So classifying femoral neck fractures as non-displaced, which includes garden grade 1 and garden grade 2, or it can be classified as the displaced fractures, which includes garden 3 and garden 4. This garden 1, incomplete fracture, complete but undisplaced, complete displaced but partially displaced, and complete fracture, fully displaced. This is the simplified garden classification. Between the neck and the head, if you see from the fracture in grade 1, because it is incomplete or valgus type of the displacement there, which is impacted, it is not in line. Whereas in grade 2, because there is complete fracture but undisplaced, they remain similar. And grade 3, again, there is a tilting, so they become not in one line. There is angle between the two. And grade 4, when there is a complete displacement, again, they come to lie in sync with each other. The similar grade 1, it is not in parallel. There is an angulation. Grade 2, angulation gone, they are parallel or in one line. Grade 3, again, there is a partial displacement. Tilting has happened to the head, and so they are not in sync with each other. And grade 4, they again become parallel to each other. Head is lying separate. And here, the trabecular of the head becomes aligned with those of the pelvis. So these are the differences that you should remember. Now we'll come to the anatomical classification. There are 3 types. One is the subcapital at the junction of head and the neck. Transcervical, it is mid portion of neck, and basicervical or basal fracture at the base of the femoral neck. Now, we know these subcapital and transcervical fractures, they are considered intracapsular fractures. There is no disagreement there. But there is a disagreement whether the basicervical fractures or the basal fractures are truly intracapsular fracture or should be kept in extracapsular fracture, and they can be treated as an extracapsular fracture, just like fracture trochanter. So this is the area which is the neck. We can see it. This is transcervical. There is another one which is called Powell's classification. It is based on the orientation of the fracture line. The fracture line which makes an angle with the horizontal line. So type 1 is when that line is less than 30 degrees from the horizontal. Type 2, 30 to 50 degrees from horizontal, and type 3, more than 50 degrees from horizontal. This Powell's classification introduced in 1935, but it is less and less used, despite it is very interesting. It is a very good predictor of the union, good predictor of delayed or non-union, but still it is not being shown that much interest that it should. Remember, it talks about the shearing and compressive forces. We'll see how it is. So say, for example, this is 30 degrees, which this line is making with the horizontal line. So this is this 30. So this is 30 degree. Now, if there is a weight, actually this is not trying to push the head away from the neck. Rather, it will compress the fractures and the union rate will be very high in these type of the fractures. Now type 2, we will discuss later. When this is the condition, more than 50 degree is the line. Closer it goes to 90 degree. Now the force on the head will be, it is a shearing force, the head will be pushed away from the fracture line and any implant that you are applying is likely to fail. Here it is compressive force, here it is shearing force. In between two is the type 2. Now we will see why non-unions is more common in the case of the fractured neck of the femur. The femoral neck has got no periosteum layer and the femoral neck fractures intracapsular means that they are being bathed by the synovial fluid and synovial fluid do interfere with the healing process. Remember, the synovial fluid contains some substances which are inhibiting factors for the angiogenesis. So they will inhibit the growth of the vessels. The precarious blood supply to the femoral head, it is going from the trochanter towards the head and not from head towards the trochanter, not proximal to distal, it is going from the distal to the proximal. Clinical presentation could be basic history is to be taken to understand whether the fracture is complete. The careful menstrual history in the lady is very important so that we can know about the osteoporosis and if it is an athlete who is a female, whether to know about amenorrhea, osteoporosis, and they have the disordered eating habits as well that may affect active women. Remember the associated injuries. So if there is a shaft of the femur, many cases you will find it is femoral neck fracture is there. And if so, then femoral neck fractures has to be treated first. What could be the symptoms? In case of the impacted fractures, it will be slight pain in the groin. Sometimes may be referred to the middle side of the thigh. In displaced fractures, it is a pain in the entire region of the hip, mostly anterior hip pain. Patient will be unable to walk. There will be shortening and there will be external rotation deformity. How to examine? You have to start with attitude. Hip is usually flexed and externally rotated. The swelling will, if at all present, it will be present over the femoral triangle. Deformity usually in the form of external rotation and the shortening and the skin. Especially in the violent injuries, you will find some bruises. Otherwise, you will find in the open fractures, say for example, gunshot injury. Then only you will find some evidence of the skin disruption. The muscle wasting usually to be seen in the late cases and that too in the glutei. Limb length discrepancy, the medial malleus, if you see it, it is the proximally placed on the affected side. That means there is a shortening. And for the segmental, you will see at the superior pole of the patella, which will be placed higher compared to the other side. It means shortening is in the femoral component. You will start palpation with the temperature, which will be normal or sometimes may be raised. Tenderness over the neck of the femur will be felt, may not be felt sometimes. Remember the anatomical landmark of the neck of the femur is 2 centimeters below and lateral to the midingular point. Deformity has to be confirmed. So deformity usually comes in the form of fixed deformities. If we talk about the fixed deformities, it will be coming in the late cases. And they are the fixed flexion deformities, the fixed abduction or adduction deformities. Remember, for detection of the fixed flexion deformity, you have to ascertain the exaggerated lumbar lordosis. The fixed abduction and adduction deformity, say for example, in the case of fixed abduction deformity, ASIS will be down and it will be up in the case of fixed adduction deformity. If there is a surgical scar, you palpate it and document it. Muscle wasting again has to be confirmed, and limb length discrepancy by confirming the levels of the malleoli. Let us come to the question, is it possible to predict which kind of the fracture we are dealing with based on shortening and rotation? Is it fracture trochanter, or are we dealing with the fracture neck of the femur? The answer is yes, it is possible. So most of the time, the shortening in the fracture neck of the femur is less than 2 centimeters, whereas in fracture trochanter, it is more than 2 centimeters. As far as the external rotation deformity is concerned, in case of fracture neck of the femur, it is usually less than 45 degrees, whereas in fracture trochanter, it is usually more than 45 degrees. But that all depends. Where is the fracture of the neck of the femur? Is it subcapital or is it basal type of the fracture? The part of the neck, in the case of transcervical fracture, is attached with the head and as well as with the trochanter. So when the trochanter wants to rotate fully, it cannot rotate because that part of the neck of the femur will abut with the capsule and prevent more rotation. Whereas in the trochanteric fracture, there is nothing to prevent the rotation, and usually the foot will be fully laterally rotated almost 90 degrees, and the lateral surface of the foot may be touching the bed. The straight leg raise test, it has to be done in the late cases where you find the chances of union has already been gone or there is non-union. Patient will unable to straight leg raise. Telescopy test is one, and there is a hop test. It is done for the stress fractures. Usually patient will have a positive hop test. Movements, don't try in the fresh cases, and the reason is that you can make an incomplete fracture turn into a complete fracture, undisplaced fracture turn into a displaced fracture. Remember, the shortening will be measurement. It should be usually less than 2 centimeters. Investigation, plain radiograph usually is required for the diagnosis. And what are the findings? The central line will be disrupted. The lesser trochanter will be more prominent due to external rotation of the femur. Femur is usually positioned in the flexion and external rotation. It is due to the unopposed action of the iliopsoas. The asymmetry of the lateral femoral neck and the head. Sclerosis in the fracture plane due to overlapping. Then smudgy sclerosis from impaction if it is impacted. Bone trabeculae will be angulated, especially in type 1 and type 3. And non-displaced fracture is difficult to ascertain on the X-ray, so it will be a very subtle one. Recommended views, AP view most commonly, pelvis including both hips is usually ordered. Lateral view, very difficult to take, so cross table lateral view can be taken. And usually the opposite hip is also X-rayed. It is due to the reason that we want it for the comparison and want to use it as a template for the intraoperative procedures. So this is the AP view of the effective hip with the leg in internal rotation. That also is a recommended view. Traction and internal rotation gives you a better view for the neck of the femur. This is the cross leg lateral view. It is done usually in the operation theater. See the image and sphere is here, and it can be taken very nicely. This is being prepared for operation. Laboratory studies are usually not necessary for the diagnosis of the fracture. Bone scans can be helpful, but they have the poor specificity. MRI can be ordered in selected cases where there is an occult fracture not usually visible on the X-rays, or when there is a stress fracture still not visible on the X-rays. Treatment is conservative for very rare cases. Very rarely the conservative treatment is recommended, especially in the bedridden patients. So the choice of the treatment is the operative one. And what are the options of the operative treatment? It is osteosynthesis, preserving the head and the neck, or replacement arthroplasty, replace head and neck of the femur with some prosthesis. And what are the options in the replacement arthroplasty? There are two options: total hip replacement, where you replace the head and the sternum both, and the indication is there should be osteoarthritic changes seen in the sternum. The partial hip replacement or hemiarthroplasty is usually recommended as a form of another replacement arthroplasty if hip replacement is considered to be too big a surgery, and where a sternum is relatively healthy. And why conservative treatment is not our choice? Remember, there are fatal complications when the patient is on the bed, and they do die with the respiratory infections, cardiovascular disease, stroke, UTI, DVT, and pulmonary embolism, bed sores, and gastrointestinal bleeding. So mortality rate is not less there. When to do surgery in patient below 65 years? There is an urgency of operation. Remember the tamponade. Pressure within the hip joint is more and they are compressing the arteries. The time is 6 to 9 hours. And what is the surgery recommended in patients below 65 years? It is close reduction and multiple cannulated screw fixation or DHS fixation. What are the types of the close reduction? Remember, the close reduction should be anatomic. Otherwise, there won't be any chance of the having the surgery being successful. So, if at all you are not getting the close reduction, a good anatomical reduction by the close means go for the open surgery. So there are three methods of the close reduction: Leadbetter technique, Whitman technique, and Well-Marling technique. So we won't go in that details. Remember osteosynthesis when we want to do osteosynthesis or when we want to do arthroplasty. When to do? So there are some conditions. Osteosynthesis is usually done when the age is below 65 years or physiological age must be good enough. Replacement arthroplasty, age should be 65 years and plus, or physiological age is to be considered. The prosthetic replacement, there are some options. What are the options? One is the Austin Moore, another is the Thompson one, and the third is the bipolar prosthesis. So Austin Moore is used when the calcare is good and a sternum is normal. Thompson prosthesis is used with the bone cement and when calcare is not so good. Or the osteoporotic bone with large medullary canal, then the Thompson prosthesis is used. Bipolar actually has replaced both Austin and Thompson Moore prosthesis, and there is less pain for the patient and they are mobile for a longer time. So what are the options in the partial replacement? We know this, the unipolar and bipolar we have seen, and bipolar by far considered to be the best one. The Thompson and Moore, you see this is the Thompson and this is the Moore. Thompson prosthesis has been applied and this is bipolar. One extra part has been applied here. Difference is the total hip replacement, the both head and sternum are replaced by prosthesis. In unipolar, hip movements occur between the prosthesis and the sternum, one head has been removed. In bipolar, a bipolar prosthesis has an additional artificial joint between the prosthesis and the sternum. The complications are non-union and AVN, avascular necrosis. Osteonecrosis is very common in displaced fracture, go up to the 45%, and it increases because of the inadequate reduction. So reduction has to be anatomic one, or you delayed the reduction, or initially there is too much of the displacement. The clinical presentation of the avascular necrosis could be groin, buttock, or proximal thigh pain, and patient may be walking. Imaging, usually plain radiographs will show segmental collapse or arthritis. Bone scan will show cold spots. MRI is the most diagnostic of all. And treatment usually, the elderly patient don't require it. You can leave it like that. Some of the patients who do require, you can do arthroplasty, but the result is not so good. What will be the treatment of avascular necrosis in young adults? The most common method and most commonly used, the first part of the any operation is co-decompression. Co-decompression means the part of the necrosed bone is removed and extra space thus created, it will stimulate osteogenesis. Can be done bone graft. Many times you do the co-decompression and the space which has been created, put in the bone graft there, which will stimulate osteogenesis. The regenerative treatment is many times nowadays employed, and this regenerative treatment is based on bone marrow aspirate. You take out the bone marrow from the iliac crest, concentration is done, and then it is put in the place where avascular necrosis is going on. It can grow in any of the cell type, but it needs more of the study. And there can be, in some cases, total joint replacement. That is also a part of the treatment in young adults, not usually preferred.